Are we waiting, Drew?
No, we're live. Hello, everybody. Welcome. We're just waiting for folks to gather. So if everyone can just give it one moment, we'll join you shortly. Thank you for attending today. All right. Well, I think as we wait for people to roll in, I just want to make good use of our time. I'd like to welcome everybody to today's installment of There Is No Normal, Only New. This is our fifth edition of webinars, and today we're focused on what's vital to the future of health and understanding the situation that everyone is now in with the pandemic and how it's affected us, and taking a look at what behaviors are new, what behaviors are here to stay, and in particular how the advent of new technology and the situation we're in have combined to create some great opportunities for brands and for consumers and patients alike. And I think we've got a great panel and a great opportunity to have a really fun and interactive discussion today. As we go through, I'd encourage anyone to use the Q&A function in the Zoom function bar in order to ask questions and to share comments with the panel so that we can track them, and we will do our best to address all of them. Just a quick word on format today. I'm going to do a very brief opening and introduce our panelists. Davion Harris, who's a partner and head of strategy at OBERLAND, is going to take us through the findings from some of our research, and then we're going to open it up to a fun and engaging panel discussion with our great colleagues today. So at the end, we will make sure to address, like I said, the answers to answer some of the questions in the Q&A. But welcome everybody, and off we go. Just for those of you who haven't been following the series on a regular basis, OBERLAND has been doing research through Suzy, which is a real-time panel of over 1 million American consumers to understand shifts in behavior towards virtual care this year for this survey, and the changing behaviors regarding telehealth. We looked at a sample of over 1,000 respondents, U.S. consumers between 18 and 65. We asked them a series of questions, which we're going to talk about shortly. I do want to acknowledge the folks at Oberland who helped make this possible. Alex Borelli, Arnell Bosk, Bill Oberlander, Cam Scott, Davion Harris, Drew Nanda, Gloria Lynn, Jen Comato, Matthew Bach, Ali Karen, Sarah Kasarski, and Ty Steinhauser. And I'd like to especially thank our panels, Neil Leibowitz, Debra Bass, and Colleen Sellers, for joining us today. It's great to have you. And I'd like to just spend a minute on the next slide, if you will, just giving everybody a little bit of background on who we've got on our panel today. So Davion Harris is a partner and the head of strategy at Oberland. Like I said, she comes to us after building a long career at JWT and other agencies, really with a deep understanding of intergenerational insights, with a particular emphasis on millennials and Gen Zs and how their behavior affects the rest of us. She's been instrumental in creating all of this research, and she's an important part of our team. And we're very glad to have her introduce the findings to you in a moment. I'd also like to welcome Debra Bass, who's the Chief Marketing Officer of Nuvo. Debra is an emerging leader in Nuvo is an emerging leader in the maternal fetal health field with a bold ambition to reinvent pregnancy for the 21st century. Debra has a BA in public policy from Duke and an MBA in management from the University of Michigan's Ross School of Business. And before joining Nuvo, Debra spent 15 years at J&J in a variety of leadership positions, including as president of global marketing services for the J&J consumer companies. I'd also like to introduce Neil Leibowitz, who is the chief medical officer at Talkspace. Dr. Neil Leibowitz, a psychiatrist, attorney, and in addition to being the CMO at Talkspace, which is a medical technology company that provides mental health treatment. He received his MD at New York Medical College, his JD from NYU School of Law, and a BA in economics from Johns Hopkins. And he was previously a senior behavioral health medical director for United Healthcare and a faculty member at the Albert Einstein School of Medicine. We are very excited to have him here as well. And last but certainly not least, I'd like to introduce Colleen Sellers, the Vice President of Marketing at TytoCare. Colleen is an award-winning leader in US and global marketing. She's driven growth in top brands as well as challenger brands by developing strong insight-based marketing plans that redefine categories and channels. Prior to joining Tyto, Colleen worked at J&J in both the US and Singapore. She's an alumni of Boston Consulting Group and holds degrees from Smith College and an MBA from the Kellogg School of Management. And Colleen also has the great good sense to be an Oberland client, and we are very grateful for that as well. And so with that, I'll turn it over to Davion Harris, who can introduce some of the findings we've uncovered about virtual care in 2020.
Great, thanks Drew, and thanks to all of our panelists here with us today. Excited to open the discussion up, but first wanted to provide some context around the research and the discussion that we'll be having today. So, obviously the last 7 months have been one unexpected event after another between the global pandemic, work from home, school from home, tumultuous election cycle, much more happening. And so during this time where we're seeing this day-to-day, constantly changing, it's only natural that we're seeing this kind of search for control, right? And wanting to have more control over our lives and in areas that we can, specifically in our health and wellness regimens, as we're seeing. One prior study, we found that 83% of Americans are more stressed since COVID began. And so it actually makes sense that with that, we're seeing 84%, kind of matching that feeling of instability and chaos, with people just doing what they can to proactively care for their health. And that's changed, in a number of ways, right? As we think about being proactive with health, whether it's increasing vitamin intake, exercising more frequently, and specifically as we look at health innovations, whether it's telehealth and tracking, we're seeing increases in wearable technologies usage. 64% of Americans actually said they've started using more wearable technologies so they can better track those lifestyle habits they've made during the pandemic. And interestingly, we're actually seeing men driving a lot of the shift or the change or the uptick. So more men, and across the board, we'll see that coming and playing out in the telehealth space as well, are starting these new behaviors as it pertains to being more proactive around health and wellness. And so, thinking about brand response, right, and brands that have pivoted, obviously Fitbit has been in the space, in the wellness space, and particularly a wearable tracker for a long time, but they actually launched a new version of the Fitbit called the Fitbit Sense that, not only tracks steps and heartbeat and so forth, but also body temperature, stress levels, and even oxygen saturation, which is interesting, especially given COVID concerns and making sure that you are aware of any shifts or changes in oxygen. They've also created a mindfulness tile that connects with other brands like Active, Aura, and Breathe to kind of help combat stresses accompanied by, COVID and everything that's happening from this past year. And so as we think about other brands and opportunities that, where we can pivot, we'll have that discussion shortly. But, want to also talk about telehealth in particular, since that's obviously something that has changed as well. 71% of Americans have attended or gone to a telehealth visit during COVID, right? And that's very drastic compared to the 9% thereabouts who were using telehealth visits prior to COVID. And so definitely a huge shift there. And so while you might be thinking this is a fleeting trend that could reverse once the pandemic ends, what we're actually seeing is what it might have started as a stand-in for in-person care, it's quickly become a preferred method of healthcare and management. Actually, 6 months into the pandemic, found that only 22% of Americans say they're only using telehealth out of necessity. And so leading to this next stat that actually 71% of Americans say they'll continue using telehealth technology beyond the pandemic, which is obviously the more important thing to look at, that this is not just about what's happening right now, but this habit and usage of telehealth will continue. Interestingly, when we looked at those who had a first telehealth visit during the pandemic, 92% of those are likely to continue. So it's more likely if people are doing something for the first time during the pandemic, that behavior will continue. So even more opportunity as we think about those brands that are looking to engage in that telehealth or virtual health space. ZocDoc, interestingly, they really needed to pivot their model. Obviously, when in-person bookings quickly fell off at the start of COVID, in less than a month, they were actually able to turn their online booking platform, which was only for in-person visits, and actually add a virtual health booking platform to meet this new need. And this was really mutually beneficial for both the patient who still needed to do visits and then, had concerns around safety and so forth, but also the healthcare providers, as it enabled the doctors to stay in business while the patients could get the care that they needed. And then as we turn to therapy in particular, right, a lot of telemedicine often focuses on physical health and wellness, but we've seen these upticks in virtual therapy as well, which is not surprising, of course, given that 83% people reporting being more stressed. But again, here, what was initially done out of necessity due to office closures and safety concerns is now becoming a new normal for many. So specifically, we saw that nearly 1 in 3 or 30% of individuals who had attended therapy in person prior to COVID say they will now opt for virtual sessions even post-pandemic. And again, we saw this shift in people who started to go to visits virtually. So if people, were for the first time doing therapy in COVID and did it virtually, 89% are likely to continue that behavior. So it's essentially, easier to keep those people in virtual, just like with the physical health and wellness visits, if they started that way in COVID. So thinking about segmenting audiences, it's a big opportunity there. And then, finally, as we think about access, right, there's a lot of emphasis on accessibility of health innovations and technology, making it easier, doctors on demand, et cetera, results on demand. But there's also a lot of exclusion that comes with virtual health and telemedicine and health innovations, right? So we found that 40% of those Americans making less than $75,000 in household income aren't able to use health technology due to the high price points or insurance requirements, right? And so it's ever more increasingly important as we think about how brands can meet the needs of people that don't have the access, whether it's around socioeconomic status, insurance, et cetera. And what we found was, regardless of income level, actually consumers in general across the board feel that health technology should be more affordable. So though, the top thing or attribute around what health tech brands could be doing to better connect was around affordability. So thinking about, again, how can those virtual offerings be made more affordable and accessible? And Lululemon actually had a good example of this. Traditionally, obviously, a brand with a higher price point in general, but they were actually able to forge a partnership with the United Nations Foundation to actually expand a mental wellness program called Peace on Purpose. And it began specifically for UN workers as a library of meditation tools, but they actually opened it up for everyone to use. So whether it was, apps or meditations to help people sleep or to de-stress, it's all available free of charge for anyone on their website. So with that, I want to, we'll take this off screen and open it up to our panelists with that context in mind. And one of the first things I did want to pose to the group here is, all of you are in businesses or in companies really centered around delivering care virtually, right, in some way or form. And so, which we know prior to COVID, it was challenging from an adoption standpoint. And then we saw this surge in demand and profitability that will likely continue as we go through the pandemic. But I'd like for you to talk to us about how you've had to adapt, right, or pivot your business model due to COVID, and how you plan to ensure consumers don't walk away from virtual care once life returns to normal. So Neil, I'll start with you, and then we'll go around.
Thanks, and it's really great to be here, and I really enjoyed your presentation. It really anchored the discussion. So at Talkspace, we were hopefully in our minds built for this moment as a technology company that's been providing virtual care for almost 9 years at this point. That said, when it came, you never can quite fully prepare for what has been a more than doubling of our business in the last 6 months, probably about 125% growth. So what we had to move from, which was from a stable growth mode to a rapid growth mode. So first is our network. We use live therapists on the back end of what we do. We offer care with psychiatrists, therapists, and within our therapists, some is video like we're on today, and others is asynchronous. So you're with a therapist and you're communicating daily, sending them messages, text, audio, and video. We had closed 33 states to new therapists. We're now opened in 50 states. So the first thing was preparing to beta test that business that every technology company says we're ready for. When it really comes, the question is, are you really ready for it? We did learn. We had some trials. If you go on the App Store and read about some of our customer service fails, we had a significant customer service fail. We've doubled the size of our customer service team because when you double, sometimes some things break. I wouldn't say we broke any one component and we came through, but there were definitely growing pains. And then the second piece is it makes you think about, and you spoke about, how do we keep people in this medium? And now that overnight, everyone in the medical field has opened a virtual practice in some way, shape, or form. How do you adapt your business to make it more sticky? And we've done a couple of things there. I'll highlight really one or two. One has been, we expanded on our marketing, and Michael Phelps, for some of you know, we've worked with him for quite some time, and we added Demi Lovato to our brand as a spokesperson. So helps with our target, but also that brand in the virtual world becomes even more important, especially now that I feel like a new competitor comes up literally every day. So that's really been key. And then the other thing is looked at our stack as to what we can add. So we've been adding content in addition to that live care as a way to position ourselves and have people, maybe they don't need therapy, but what else can we give them that keeps them in our ecosystem? And we've been working on expanding that content and what I would call self-service offering as well, which is a work in progress.
Great. Thank you for that. Debra, what about you from, a Nuvo perspective?
Sure. So Nuvo is a little bit earlier stage than TytoCare and Talkspace. So we got our FDA clearance in spring of this year for remote pregnancy monitoring, and we're getting ready to launch on the market late Q4 of this year. So for us, we describe COVID as elevating remote pregnancy monitoring from an unmet to an acute need. Because if you look at the pregnancy population, expectant moms are deemed a vulnerable population who should socially distance. OB clinics either were closed in the height of COVID or had restricted access. Yet this is not like an elective surgery where I could defer it for 6 months, right? Moms can't go unchecked. So we saw COVID accelerate us for remote pregnancy monitoring from an unmet to an acute need. We've also seen a surge of demand before supply, like good problem to have, but tough problem to have as a startup. So it's really forced us to do 3 things. One is to get really laser focused on priority adoption customers, because we can't do a little bit everywhere. We need to double down and really get a foothold in this market. 2, it's really forced us to beef up our virtual offering end to end in terms of virtual training and implementation and patient education, et cetera. And then it's also challenged us to build a global company even more virtually, right? So I've hired people virtually, we've onboarded them virtually, we're forming as a team virtually. So it's really been an accelerant for adoption and challenged us in terms of how to get off the ground with focus and might.
Great. And Colleen, really curious to get your thoughts on this, since, with TytoCare in particular, you were in that 9% of seeing the utilization and, all of a sudden you saw the demand just surge.
Yeah, and so thanks, Debbie. And I think it's actually very similar to what Neil and Debra said. And for those of you who don't know, TytoCare is a handheld device that allows you to take medical grade exam data of your ears, of your throat, of your lungs, and your heart, video clips of them, and send them to your provider. And so our differentiation pre-COVID was actually that utilization rate, where you saw most hospital systems or health systems at 5%, we could get you up to 40% utilization because it expands its use case and really gives credibility to virtual care, kind of bridging more concretely a video visit into a physical exam. Now, what happened with COVID is it was clearly accelerant, like Debra said, and all of a sudden, like I joke that our unaided awareness of telemedicine was basically 0 before COVID, but the aided awareness was like at 50%, I would say. Like if you talk to someone about it, they'd be like, "Oh yeah, I think I got a postcard in the mail about that." And now we're having webinars about it, 1 a week, right? So you're at 100% unaided awareness. So it really accelerates you 5 years ahead of yourself in terms of consumer readiness for adoption. Now, a lot of that use is theoretical, right? Or they used it during COVID. And now we have to think about, how do we make them sticky? What are the marketing campaigns that really engage with them? And what other tools do they need? What other products do they need to make this a great way of delivering care? And I think that's the thing that we really have to understand. And it came up a little bit with what Neil was saying is, our healthcare system is very fragmented in this country. And so state by state, city by city, what you do for healthcare changes. And that makes any technology that you try to roll out on a national level challenging, from, you know, like all the pieces that need to work together, all the providers that you need, all the you said in your slide, the reimbursement for some people is great, for some other people isn't, which makes understanding virtual care kind of confusing to a consumer. So how do we really educate the consumers so that they're getting the best care for themselves, as well as the provider side of this, right? Like, we can't forget about the providers in this whole thing. So I think that's really some of the work that we've been doing and we need to continue to do.
Absolutely. And I'm glad you mentioned providers there, because I think there's, you know, an obvious assumption, or, you know, right, that we're in COVID and everyone should just be adopting telemedicine or telehealth, but there are barriers or, you know, implementation considerations for large hospital systems and so forth. And so thinking about, you know, the moment that we're in, where it makes sense in many ways to adapt and to shift your model to be centered on virtual care, but then at the same time trying to convince overwhelmed, overworked healthcare providers to, you know, make this onerous switch or change. How are you juggling that? Colleen, I'll start with you.
Yeah, so I think that, you know, for the most part, our business model goes directly to large health systems, and we purposely made TytoCare technology agnostic. So it can integrate into your EMR, it can integrate into all your software, so that you can have, it's a full stack telemedicine platform. So it can kind of adapt and customize to the healthcare system. I think that's really important, because the last thing a provider needs is another set of check boxes and another sort of, like, you know, for lack of a better analogy, another app to go through. So that was the first thing that we did. And I think the second thing that is really important to this is around reimbursement. So before COVID, there weren't parity laws across the country. So some states, you got reimbursed the same amount for a telemedicine visit as you did for an in-person exam, but in many you didn't. Medicare in particular didn't do that. And so when the Health Emergency Act went through and actually changed a lot of the reimbursement on a trial basis, that's where we saw a lot of adoption, because it changed and drove parity between virtual visits and in-person exams. And I think that that's where that understanding, it's not just that, you know, you have to train the doctors on using the new device or train the IT departments. It's also all the way through the economics of it. And I think that's where, again, you know, the state by state fragmentation creates issues, because it could be different by every state. And as Neil said, he was onboarding, I think, what did you say? You went from 33 states to 50 states. That's a massive amount of work to kind of go, you know, almost 50% increase in the number of states. And so I think those are things that we've been doing. And I think that as we look forward, as many of us that are in this space and can really advocate for some of these reimbursement changes becoming, you know, full-time and official, that'll be crucial to making sure that we have use of telemedicine continue, and also the access points that you were talking about before, Davian. A lot of that is actually about insurance reimbursement.
Absolutely. I mean, when we think about going back to kind of the future of telehealth and telemedicine, and so, you know, we found the 22%, right, are only doing it out of necessity, right? So there's a lot of people that are seeing the benefits of telehealth, whether that's the convenience, not leaving your home, you know, the cost, et cetera. You know, there's still the quality of care perception, right? And, you know, not having your own physician all of the time, feeling like you're getting less of a, you know, thorough visit, right? So how do you see, from a marketing standpoint, you know, how you can communicate that kind of elevated level as we go out of COVID and people are able to return to the normal? How do you keep them feeling like virtual care is not necessarily even superior, but just as good, or something that they should continue adopting and continuing. Debra, what are your thoughts on that, especially from a pregnancy perspective? I imagine, especially, you know, and I know you had noted that it was the second time moms, interestingly, who were kind of a sweet spot because they had gone through it before. So thinking about, you know, a first time mother or somebody who's a little more sensitive, I mean, how are you overcoming that factor of feeling like they're not getting the quality of care from the in-person visit?
Sure. So I'll first share more on that insight of the second time mom, which is a little counterintuitive to me because I thought the first time mom would want to make sure she got everything perfect, including using the latest technology. But what we learned from our OBs is the second time mom is less jittery and more attuned to the burden of care and more in need of new solutions to alleviate that. So I almost think of this as omnichannel care, right? So if you think of retail, right, it's not brick and mortar or e-commerce, it's both. We at Nuvo believe in distributed care, that the mother should be the point of care and data should travel across the home, the hospital, and the doctor's office. So as an expectant mom, we don't want office visits to go away, but we think that they should be rationalized to the critical few visits where you could bundle in blood chemistry and imaging and other procedures that are needed, and then start to distribute more of that care to the home so mom could more conveniently receive her care. She can be empowered with more data. She could share that bonding experience with a partner, right? Now you can't always have your partner at your visit to hear fetal heart tone, you know, et cetera. The floor of telehealth is what we call a no compromise visit. Do what you're doing in the office and match the quality virtually, and maybe get some edge factor on convenience. We believe over time, though, that telehealth will actually create a more meaningful virtual visit because it will be more personalized. You'll get more data to be more empowered and knowledgeable and more of an equal partner in your journey. The convenience is unmatched, particularly for pregnant women who don't need the exposure of incidental contact and stress on their system. So not either or, but and distributed care, I think, is how we see it.
And Neil, what is your perspective on that? Because I imagine from, you know, a therapy perspective, there's something to being in person with your therapist and having that connection, especially if you've never even met the person before, you know, that being a barrier. But at the same time, knowing that maybe some people feel more comfortable having the screen or as a barrier. I mean, what are you seeing there in terms of the differences, and how are you thinking about adjusting or messaging accordingly as we move forward?
It's a really large ecosystem. And I think when you think about the numbers, the number I anchor to is a little bit different than some of the numbers you cited, which is 75 to 80% of the people who've had a virtual behavioral health visit, and I think it's not that dissimilar for medical, had a good experience. So how that plays out is a little less clear. Maybe some people want to see their psychiatrist in person, they don't go as often. Maybe they want to see their therapist twice a month in their office and twice a month virtual. My sense is that the adoption will remain high in most cases, but when people are sort of asked that question, are you going to stick with it? It's less clear. They're not really thinking about it in terms of how it fits into their lives. I mean, we spoke a little bit about pregnant mothers. If your child has a sore throat at 7 p.m. at night, maybe at least for me, I can either go to City MD, it's down the block. I still got to go outside. But what if I'm in a place where going to City MD isn't just outside, and now I got to go in my car in the snow? So I think the use cases are vast and broad, and it's not a I'm doing it or I'm not doing it, I'm going back to it or I'm not going back to it. I think it's more of how will it fit into me individually. And what's been really nice, both from what we do, from what my panelists do, and what a lot of other people and companies are doing, is we're broadening the offerings. And whether we think it's a great idea or every idea is great or not, the Hims and Romans offer a service that's beneficial to a group of people. There's a consumeristic nature. In psychiatry, there have been subscription models being launched. We're a session model. So there are multiple models. Some will not survive, some will. It's a little less clear which are going to be the quote unquote winners. But I think what we've been able to do very quickly is offer people a much wider array of choice And the regulatory environment is moving towards allowing that and agreeing. And in the next probably 2 years, I think we'll see some significant movement that's going to open up that choice. And for me, it's about giving people the opportunity to access care on their terms, because when we tell people you must do this, does my kid really need to go to City MD? Is their throat hurt that much? Is their nose running? Can I get away with sending them to school? Do I need to do all these things? And we start making those decisions. We don't think about them, but we make all these decisions. So I think having an expanded array give people that choice. And I think people can make good choices for the most part and figure out what fits. And I think for 90% of the population that's tried telehealth, they will have a telehealth visit in the next year, even when things revert. Question is, will it be 5% of what they do or 80% of what they do?
Absolutely. No, I love that sense of choice and giving people more of the options as opposed to it being one or the other. Colleen, curious if I know you have thoughts on that, since we've talked at length about, it was in Tyto being a device, obviously in the home, right? There's the idea that you can use it in place of, right, that urgent care visit at 1 a.m., but there's also a way to implement it in your life just from a health management perspective, ongoing and supplementing, as opposed to replacing care. So love your thoughts on that and what Neil is saying.
Yeah, I mean, I love this construct Neil has of choices, right? Because every day, actually that kid at 7:30 that has a sore throat, then the next time that might be sleep on it, and we'll see how you feel in the morning. But the next one might be so bad that they can't sleep on it, right? So I think that being able to have choices, and for consumers and parents to really understand what the choices are, I think is part of the opportunity with virtual care. I keep on coming back today to the fragmentation of healthcare, but healthcare is really confusing to consumers. I think if it's mental, all of this, right? Like you're a pregnant mom and you're like, really, I'm coming every month to the doctor. Is that covered by all these visits covered by my insurance? Like, they're all hard, right? Figuring out your mental health benefits on your insurance is very challenging to do if you even have them. And so I think what virtual care has the possibility of doing is creating transparency. So you can make the right choices for yourself and your family. And I think that that's also what some of these offerings are, right? The TytoCare device, if it's in your house, then you can make the decision. You have much more power and empowerment over your healthcare than you did before. That's why I love all of this health tech, and is that it really does. Like, we've been talking consumer health for 10 years about powering the individual with healthcare. And for a long time, it was about steps or the sleep data, which was immensely powerful, but very much, it wasn't the core data that you need to figure out healthcare, right? So now we're getting to the point where we could have a consumer actually have their lungs, a recording of their lungs taken every day. We're getting to the point where we have AI and machine learning that can alert the consumer to a potential episode, like, actually, I'm starting to hear some wheezing in your lungs. Maybe you want to send this to a doctor. And all of that is being done, kind of like you brush your teeth, right? You still brush your teeth. You still go to the dentist when you brush your teeth every day, but you're not going to the dentist every day. I think that with virtual care and devices like TytoCare or Nuvo, and even Talkspace, right, where you could text a therapist, when you need it, that doesn't always become the full complement of care. It becomes additional. And it gives you, as the consumer, that choice to, kind of make those visits when you need them. I was talking with a potential partner the other day, and he was saying, oh my gosh, my kids have ear tubes, and I have to go to the pediatrician or the ENT every 3 months to make sure they're still in. And he's like, can they see those? And they definitely can see the ear tubes on the TytoCare. So imagine 4 times a year, instead of making the appointment with the ENT, sitting in the waiting room for an hour, driving, right? A lot of our citizens aren't that close to specialists in this country. They don't have the access we have in big cities. And so you can imagine that time back in both the patient's life, right? But also the provider's life. Like they can now review these things asynchronously and send you feedback because you don't need to have that visit. And so I think that as we give transparency, we give choice, and then we give empowerment. And I think that helps both the healthcare system and the individual and the providers.
Absolutely. Absolutely. Yeah. I mean, it begs the question of what does the future of care look like, and what is that optimal mix, right? Is it this 90% virtual and 10% in person where it's really needed? Is it 50-50? So yeah, definitely.
I think there's a really good example that I think we should share right now, that for instance, children should go to do their well visit with a pediatrician every single year, in part because they need their vaccines, and that's where you get the vaccinations. So something like TytoCare should never replace those well visits with a pediatrician. Where it replaces it is, like Neil was saying, like his 8-year-old has a sore throat, or maybe has a slight fever, and we've all been in that situation where you're like, is it an ear infection or just a virus, especially now during COVID. And so to be able to do that exam in that moment, that's where I think you need to have that balance, right? You need to go for the vaccines, but some of this periodic care could easily be opened for virtual care.
Absolutely. Debra, I'm curious, and you kind of alluded to it in terms of pregnancy monitoring. I mean, barring a high risk pregnancy or something happening, could the 40 weeks be done potentially all virtually with Nuvo?
They could potentially be done all virtually longer term. In the near term, we don't cover things like blood chemistry or imaging, so not in the immediate term. But if you think longer term, Colleen was talking about big data and AI, right? Where we want to get to with Nuvo is to go from passive monitoring to proactive management, right? And if you start really building this big data and AI machine, which we're sort of on this journey to build, you would know, Debra Bass at 20 weeks has risk factors of preterm birth and gestational diabetes and whatever. And knowing that, I'd be on a differential path for management, much of that self-care, right, to be preventative, and then complementing that with office-based visits. So I think that's point one, right? We can't cover every procedure, but more and more of it can go virtual. I think the other reality too, kind of like Colleen was saying with the pediatrician, it anchors some procedures like vaccines and pediatrics. It also anchors some of that relationship building with the OB, which is such a critical actor in your life, right? I'm trusting that person with the birth of my child. So I think there's also some relationship building that you want to establish in person and that you can carry on virtually. But I think more and more of it can and will and should shift to virtual. And over time, virtual will be much more enriching than that burdensome in-person requirement.
Absolutely. I want to switch gears and well, first I want to encourage anyone in the audience to submit questions, because we can definitely get to those. But I do want to go into some of the data points around access, and specifically, thinking about cost, insurance. Obviously, in this case, we have the stat that 40% of Americans, with that 75K or under 75K household income don't use the health technology, for instance, virtual care and then other devices due to the high price points and insurance requirements. So how are you, in your respective companies thinking about, creating more of that access and opportunity as we think about people from diverse socioeconomic backgrounds? I'll start with you, especially, you talk about content, right? And so I know, for instance, there's blog content and other resources that are free and available to anyone to use, that you don't need the subscription. But curious, as you think about, mental health support, in particular in resources? What are some of the ways that you've already or are planning to address those audiences?
So some we've done, and we, for example, when COVID started, we created several free Facebooks moderated by therapists. And we had several thousand people in them. It was for people who needed a little bit of help, but really didn't need a therapist. So that was one. And we had a large donation to frontline responders as well as part of that. So all those were things that we felt were more urgent and pressing. But from a long-term view, there's sort of two factors. One on our end, which is enhancing the content and potentially offering some subscription. When people think about Calm, for example, which is, I would say, a wellness world space, it's in the wellness space. So going a little bit downstream at a much cheaper price point. But the more important one, I think, from where we sit, because really our core is licensed therapists, and that's what makes it, that's the secret sauce, is having someone who's a professional who can deal with complex problems, is the shift in where the payers are. They're all working on their strategy, that digital health strategy that's been in the works for 2 years but hasn't really materialized. It will materialize. They don't have a choice now. Employers are now looking at wellness in a different way. We thought our employer business would be very, very quiet with the pandemic, just from a cash conservation standpoint, and new initiatives wouldn't happen. We're finding that they're happening. Yes, it's unlikely that an airline's going to call us and say, we're thinking of rolling this out financially, but our enterprise direct to employer business is surprisingly extremely healthy and is expanding. So I think there's that messaging, and employers are starting to realize, especially as people are remote and they don't have a pulse on them, that offering things that are somewhere in the medical or even the wellness world become much more important. So I think the affordability paradigm starts to change. We can do some things. The three of us, at Panelists with our companies can do some work, but I think a lot of the work is really on the institutional healthcare side. And we work and partner with many of these groups, so we're part of that solution. But what I am very positive is I'm starting to see that shift and focus where they're really looking at this as part of what they do and how they see their companies and their mission.
Colleen or Debra, were you gonna jump in there?
Yeah, I mean, just on the access point, I would actually, say sort of two angles. One, just the inherent value of remote pregnancy monitoring. I was shocked, my first week of work, I was eager beaver and the antenatal testing unit at Einstein, and all I wanted to do was watch like non-stress tests, right? Because my kids are 17 and 19. It's been a long time since I've had one. And I kept saying to the nurse, when's the next patient? When's the next patient? And she said, oh, Debra, the schedule is a joke. These patients show up when they're able to show up and don't show up when they're not able to show up. These are high-risk pregnancies with a 30% non-compliance rate because the burden of care is just too great. And for the average American, not any of us on this webinar, right? I have to leave my young children, hire a babysitter, pay a bus fare, not get paid for a part-time job I'm leaving later, right? Just the burden of care is just too great. So one, we're expanding access to the underserved just through the inherent value of what we're offering. The second way is actually through partnerships with Medicaid-leaning institutions. In our case, University of Arkansas Medical Sciences in Little Rock is one example, where much of their population is Medicaid, and they're a rural site of care, right, where moms have to travel hundreds of miles to see a maternal fetal medicine specialist. So serving that patient through better access and digital tools and a regime that they're able to comply with, either standalone or with the Medicaid and institutional partnerships.
Right, Colleen.
Cool. Yeah, I'd like to talk about it in two ways. I love what Debra was saying about value. What is true about TytoCare is if we look at it from an avoidance of an urgent care visit like CityMD or an emergency room visit, which is also very, like, the use of emergency rooms for non-critical care is pretty high. You return the cost of a TytoCare in literally one avoided visit. So we've been partnering with a couple, actually, and this is a good silver lining for COVID, right? COVID accelerated payers' willingness to work with and willingness to kind of study and pilot with startups like us and probably Nuvo. And so we're working with a couple of them on pilots to understand actually that value. So like, I mean, the fact that you could get more moms being more compliant with prenatal care probably has, I hate to say it, a cost. I mean, it has obviously better health outcomes, but it probably has a cost advantage too. And so I think that the more of these small pilots that we start running with the payers, the more access we'll get, because that's when they'll start supporting and helping to provide reimbursement for it. The second thing is thinking about how virtual care technology literally expands access to care. And I know, Davian, you know this, but we have a program with Tyto. So Tyto is a small device, but we also have a version of it that becomes Tyto Clinic. So it's our device with an iPad, and it can become a replacement for a medical cart in either a school or assisted living facilities. And this cart that exists, that a lot of people use for remote patient care, costs about $50,000. It's a computer with a bunch of peripherals that are attached to it that are not meant to be attached together. And so it becomes fairly hard to use for either the nurse or the medical assistant, and it just breaks a lot. So we created TytoCare because all of it is integrated by design. And so it's designed for, you know, someone like a parent to use. So it's much easier to use. And we designed these carts to be much less expensive than the existing carts, and they have a much smaller footprint. And we started going out to schools, and we said, because a lot of schools in our country, especially in underserved communities, have lost the budget for school nurses. So what they do is they outsource student care to health systems. For instance, the University of Pennsylvania or Children's Hospital in Philadelphia does the student care for the Philadelphia public schools. And so what we do is we put a Tyto Pro in there. And what we found is that when Tyto Pros are in these schools, that they become access points to primary care. So before, where these children were underserved, either because they didn't have insurance or they were underinsured, they actually weren't going to the doctor for their well checkups. And so things like asthma weren't getting reported as much, weren't getting care for it. And they were going to the school nurse or the person in the school and complaining, and then they were being sent home. And as any of us as parents know, when you get that call from the school, that means you're leaving work. That means that you need the car. That means that you have to do something else with your young children. It's a big tax on you to go get the kids. What we found in some of our studies was that 9 out of 10 of those children actually didn't need to go home. They just needed care in the moment. So by using a TytoCare, they get virtually connected to a physician in the provider network. So, you know, at CHOP or at Jordan Valley Community Health, they get connected to that provider. That provider provides care, and 9 times out of 10, they're able to go back to class. And now they're getting behavioral health services too. So they're actually getting care. And let's say they need a prescription. Let's say they need a replacement, you know, they need some replacement. They actually have programs set up so that RX can be delivered to the child. So when the child gets picked up at school, the RX can get delivered to the parent at that moment. So really kind of collapsing and creating access to care is like possibilities through this. So I think sometimes the cost of the device is what we first think about, but we forget about the access to care, that virtual care. And it's not just children, by the way. We've done the similar thing with specialists. Like I think, Debra, you were talking about in Arkansas, how these moms have to spend, you know, go miles and miles to get to the one fetal health specialist. That's true across rural America. And so what we can do is we can actually set up Tytos in general practitioners' offices that then can do an exam to a specialist, and all of a sudden become kind of a hub and spoke model, like an airline. and maybe that's not the best analogy these days, but, and then provide care. So at University of Virginia, we did this with head and neck specialists, where your PCP did an exam that was emailed to the head and neck specialist. They, within 24 hours, would return a treatment plan to the patient. And 92% of these people didn't need to go to an in-person exam, which means that they saved all the hour drive, they saved the hour wait, and they got a treatment plan 6 weeks before they would have gotten one if they had waited for an exam. So I do think there's ways of using our technology to increase care, it's not just a friction point, it's actually a benefit.
Right. We have to think about it much more holistically than just the cost of the product or the technology itself. Absolutely. And I think also to the points earlier about that proactivity, right? So if you're catching things, monitoring, and catching things before they become issues, that's a cost savings for everyone in the system. We do have a question here. This one's for Neil. So to what extent do you think that the uptick of virtual therapy services like Talkspace have reduced stigma surrounding therapy and mental health overall?
The last brand in mental health was probably Sigmund Freud. And I say that tongue in cheek because healthcare is notoriously behind every other industry. And, while we don't always like to admit it in the physician world and the clinical world, is having a brand is really important because it really gives people an anchor to getting care. So first, I think it's huge. And the work that a lot of us are doing in the mental health space and the medical space is really about promoting what's available, what's out there, and making people more comfortable with getting care. So that's been very valuable. Maybe on the Upper West Side where I live, if you don't have the therapist, you're the outlier, but in many parts of the country, there is still stigma. The other reason that it's pretty valuable is that people sometimes won't go to an office. Mental health, but not just mental health, medical as well. There's still a lot of stigma surrounding just walking in, going into a waiting room, both in our minds, where I'm uncomfortable walking in some places they may see me, or it's a small town, or people will know. And we see that especially with things like post-traumatic stress, where veterans still don't access care. So virtual care, not only through that branding and marketing, can reduce stigma, but allowing people to do things from the confidentiality of their home really decreases that stigma as well. And if I wanted to find out, about STDs, yes, I need the test in an office, but can I be screened virtually? Yes, because people don't want to go into an office for these type of things. So it's sort of that mix of brands as they emerge and the ability to have that confidentiality that feels like anonymity in a lot of ways that really helps reduce stigma, but not only in mental health, really in the whole healthcare ecosystem.
Absolutely. And I think that's also beyond the stigma, but you touched on just the discomfort around, healthcare, right? That some, and particularly minority communities, often experience, and we've seen the data on that as well. And so virtual care really providing that opportunity for more people to get that access and be seen. So we are coming up on the hour here, and I wanted to first just thank our panelists for their incredible insight and participation today. So Debra, Neil, and Colleen, thank you so much. And thank you to everyone who joined us today. We're looking forward to continuing this series of There's No Normal, Only New. So be on the lookout for the next topic. So thank you very much and enjoy the rest of your day.
Thank you.
Thank you for having us, Davian.
Thank you.